This program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest UCTV programs.
I'm giving half of the what's new, what's hot, so maybe I'm going to be the what's new and Sindhu will be the what's hot. It's much more cool to be hot than new. So the first thing I'd like to just go over is something we talked about last year called hope. And to this year, we'd like to ask you if there's hope after hope. So what is hope? Well, there's our fearless leader, Dr. Peter Stock, with Barack Obama. I think Peter is our fearless leader. I'm not exactly sure what Barack is. They are signing the HOPE Act, which apparently, and Peter can tell you more about this, President Obama was super excited because this was one of the few pieces of legislation that actually made it through Congress. So the HOPE Act is the HIV Organ Policy Equity Act, and the bottom line is we're now allowed to. Previously, it was illegal. We were breaking the law if we did so. We never did so because we're law-abiding citizens, but now we are allowed to use organs from HIV-positive donors for transplantation in a study setting. And so that was actually signed a few years ago, and now it's actually coming to pass. Now, the law was based on an experience that was published from South Africa. And this past year, there was an update as to the original experience, results of kidney transplants from HIV-positive donors into HIV-positive recipients at 3 to 5 years. There were 27 transplants performed in 25 patients with follow-up in that period. Creatinine was actually, as you can see, quite outstanding. Patient and graft survival is shown over in the right, and what you have is you're comparing patient and graft survival of the HIV-positive couple, the donor-recipient couple, to the HIV-negative donor-recipient couple, and you can see that they're not significantly different. There were 5 deaths in the HIV-positive group for the reasons shown there, at the times shown as well, and there were 8 rejection episodes in 5 patients, leading to 2 graft losses. So the rejection was 8% at 1 year and 22% at 3 years. So really nothing about these transplants seem at all unusual or untoward. Now, the HIV-related outcomes that were reported were that the CD4 positive T cells declined, but that was thought to be because they used induction, which depleted those cells, and they slowly, after about a year, started to return. HIV viral load was successfully suppressed in all recipients, but very interestingly, 3 patients showed early HIV-associated nephropathy. Now, remember, there was never any viremia in these recipients, and yet they showed HIV-associated nephropathy that was not there when the kidneys were transplanted. In these 3 cases, the kidneys continued to work well, but there were histological changes that were consistent with HIV nephropathy. And there was also a publication that showed that the kidney, the podocytes, and the tubular cells is a reservoir for HIV. So what does that look like? This study, published in JASN in 2014, took protocol kidney biopsies from 19 HIV-positive recipients. These were all HIV-negative at the time of and after transplant. So they had a history of HIV, the recipients, but they never had detectable virus. Yet, HIV was detected in 68% of the kidneys. And there were 2 flavors of infection. 62% had infection of the tubular cells, and a smaller percentage had the virus detected in the podocytes. Very interestingly, the podocyte infection was associated with poor renal function. And they also presented a novel non-invasive test to detect kidney HIV infection by measuring DNA and RNA in the urine. So this is what the histology looks like. So the left panel is negative control using sense RNA, and the right panel is positive findings using antisense as a probe. So you can see that on the right, you can see brown cells infecting the podocytes as well as the tubular cells. And here's the picture of the downward course when you had HIV in the podocytes. So what you can see is that the red lines are is proteinuria, so it goes up after transplant, and the black line is GFR, and generally over time, it's gone down. So I think this is very interesting information about HIV transplantation. We don't know how the HIV positive donor may or may not have an impact on this. These are still, of course, early days. UCSF is poised to do HIV positive transplants liver and kidney transplants from HIV positive donors. And so I think this is something for which you should all stay tuned. The next topic I want to cover, and there's several interesting aspects of this topic, is cancer. First, the epidemiology of cancer in kidney transplant recipients, and this whole issue of T-cell exhaustion, which came up very briefly in the talk that Flavio Vincenti gave related to the belatacept and the trying to fine-tune how to use belatacept. So what is new in epidemiology? Well, this publication in JASN was, I think, really interesting. It showed that there's variation in cancer incidence among patients with ESRD when they had a functioning kidney and also when they didn't have a functioning kidney. We all know that cancer affects the long-term survival of patients, both ESRD and transplant patients. So what they did was they took SRTR transplant data and linked it to population-based cancer registry to study cancer epidemiology in a couple of 100,000 kidney transplant recipients. But what was super cool is that they were able to differentiate periods where the kidney was working versus periods where the kidney was not working. And so here's some of the data that they showed. So let me just take you through this slide so you know what you're looking at. Basically, it's not just, sort of a sawtooth graph. On the bottom, you can see that there is WL waitlist. So that is the incidence rate when people are waitlisted. The next point is at the time of the first transplant when the kidney is working. The time after that is during the graft failure time of that first transplant, followed by a second transplant, followed by graft failure. And what you can see is that for infection-related types of cancers, and we'll tell you which ones those are, and for immunologically related types of cancers, the incidence is high when the grafts are working and low when there's no kidney transplant during the wait lists and the periods of graft failure. On the other hand, ESRD-related cancers show the opposite pattern. So when things are zigging up on the left, they're zigging down on the right because those cancers are more common in renal failure population. They're not related to immunosuppression. And then there's groups of cancers that don't have any relationship to either ESRD or immunosuppression. So this next slide might make everything a little bit more clear. Now, see, I need to kind of pull you in because you don't know what this shows without my help. That's part of the strategy here. These are hazard ratios. So if you're above the flat line, that means there's more cancer incidence. If you're below, that means there's less. The y-axis is, again, the wait list, transplant, graft failure, transplant, graft failure. Now, what are the cancers? Infection-related cancers are non-Hodgkin's lymphoma like PTLD, or anal cancer, which is sort of virally HPV type related. And you can see that zigzag where in times of graft function, when people are on immunosuppression, the cancer incidence increases. In times when there's no graft function, either pre-transplant or when the graft has failed, the cancer incidence drops. Now, Here are the immune-related cancers. These cancers are kinds of cancers that are treated with, for example, sort of immunomodulatory therapies. They're thought to be responsive to immunosuppression or lack thereof. And again, you can see the expected pattern for cancers that are immunologically related. Kidney cancer and thyroid cancer is increased in the ESRD population, and you can again see that indeed in periods of no immunosuppression, so graft failure, you can see higher incidences of those cancer and lower incidences when the graft is working. And then myeloma and pancreas are those other cancers that don't seem to be immunologically related. So I think this is a pretty interesting merging of factors for the population that you all are dealing with, and may help us think about surveillance approaches and the right and the best way to take care of these patients from a cancer perspective. Now, shifting to the next phase of cancer, I want to talk a little bit about T-cell exhaustion. Again, this came up in Flavio Vincenti's talk. It's been known that tumor-infiltrating lymphocytes are just tired. And part of the reason you get cancers is because your tumor-infiltrating lymphocytes are not able to kill off the cancers. These types of lymphocytes express multiple inhibitory receptors as shown. And antibodies against these inhibitory receptors, many of you probably have patients getting these types of treatments, are being tested in a variety of cancer trials. Exhausted cells, as actually Flavio mentioned, are actually not terminally differentiated, but they can be turned back on, because if you basically turn off their inhibitory receptors, they can basically wake up again and start to work. And there have been impressive results of anti-PD-1 antibodies in certain types of cancers. Melanoma, again, one of these cancers that's sort of immunologically responsive, renal cell cancer, etc. Now, this paper actually shows that kidney transplant recipients who have a high percentage of CD8 positive, CD57 positive cells are at increased risk of squamous cell cancer. So Flavia was talking about CD4 positive, CD57 positive. I'm talking about the effector arm, not the helper arm, the CD8 positive, CD57 positive cells. So the panel on the right shows the hazard ratio of people who have previously had skin cancer, squamous cell cancer, compared to those who don't. So clearly, people who've had previous skin cancers are at increased risk of getting more skin cancers if they're a kidney transplant patient. However, what's very impressive is the odds ratio is very similar if you compare people with a lot of CD8 positive, CD57, a lot of positive exhausted T cells. They are at similar risk of getting skin cancer compared to someone who's had a previous skin cancer, as you can see by the graphs that are shown. Now, this case report in the New England Journal of Medicine brings the story home. This is a woman who had a kidney transplant for a long, long time, 1989. And the kidney was working very well, but she presented with metastatic squamous cell in March of 2014. So I can barely subtract how long that kidney's been there. Now, the cyclosporin was stopped as part of the treatment of the cancer, and various types of chemotherapy was administered without effect. So then they suggested that perhaps they should try anti-PD-1 therapy. And this was discussed with the patient, as well as the risk of potentially precipitating acute rejection of the kidney. The tumor responded to the anti-PD-1 therapy very, very well. The burden was reduced by 85%, but lo and behold, 2 months later, the kidney was aggressively rejected, could not be reversed. And here's the histology of the kidney. You can see on the H&E, there's evidence of severe acute and chronic rejection. This was cell-mediated rejection. There was no evidence for antibody-mediated rejection. And you can see that there was PD-L1 and PD-L2 in the graft turning off of cells, but that the cells were then, the kidney was then being infiltrated by CD8 positive effector cells that were PD-1 positive and proliferating Ki-67 positive. So this is a really interesting paradigm of the yin and the yang of exhaustion. It's perhaps good for kidney maintenance of organ function, but very bad for cancer. And since our kidney transplant patients are at risk of developing cancer, I think this yin and yang will be coming up more and more. As a final sort of coup de grace to this whole story, which I think is really interesting, I'm going to pull you all kidney folks into the liver world. There are immunosuppression withdrawal trials in liver transplantation. And in particular, this trial was done in Europe, and it was focused on hepatitis C liver transplant recipients. Now, this whole thing of exhaustion has been very, very well developed, this theme, in cancer. But it's also really strongly developed in viral infections, specifically chronic viral infections such as HIV and hepatitis C. And so the real question is, does exhaustion of your T cell that has been mediated by a chronic viral infection have any impact on your ability to come off of immunosuppression and be tolerant of your liver, the organ in which the viral infection is actually occurring? And very interestingly, the answer is yes, because if you look at this picture, you can see that tolerant patients, both pre and post immunosuppression withdrawal, have a higher percentage of CD8 positive exhausted T cells. So this suggests that the exhaustion created by a chronic viral infection might have a silver lining effect on the tolerance of the liver allograft. And in some ways, we can actually perhaps think of a graft as a chronic antigen stimulator, and perhaps exhaustion might be a pathway to immunologic tolerance. And this is something that we are actively exploring at UCSF in liver transplant, and perhaps when we understand it better, we can actually apply it better to kidney transplant. So the final, what's new and what's hot, is actually distinctly not hot, it's actually cool. And I want to talk about this Klaus-Niemann study that Flavio Vincenti mentioned, but really use it as a springboard for a much bigger issue that I'm hoping you will all engage with me in. So Klaus and multiple people that you know, including John Roberts and Rio Hirose, made this big splash in the New England Journal in July of 2015. Basically, therapeutic hypothermia in deceased donor organs improves early kidney graft function. This is really a pretty elegant and amazing study, considering, if any of you remember and know the ICU setting, having your temperature down at 34, 35 degrees is really kind of what happens if you don't try to do anything. It's a product of benign neglect, and perhaps this isn't actually benign neglect, it's beneficial neglect for kidney transplant recipients. So how was this trial done? Neurologic determination of death. The deceased donors were then randomly assigned to 2 targeted temperature groups. There were non-invasive ways to manage this temperature, and it began after authorization was obtained and ended as you moved into the OR for organ procurement. And the primary endpoint was delayed graft function. And what you can see here is that normothermia had a rate of DGF of 39% versus hypothermia of 28%, or an odds ratio of 0.62, a 38% reduction in the incidence of delayed graft function, which was highly significant. If you look at the flavors of kidneys, ECD kidneys, the upper group, had greater benefit because the SCD group crosses the line of 1.00 for odds ratio. Those dual kidneys that somebody asked the question of had an incredibly improved outcome. There were no kidneys, 0 out of 5 in the hypothermia group that had DGF, whereas 5 out of 6 had DGF in the normothermia group. And as you can see, overall, there was a statistically significant result. Now, one might wonder, gee, this is great. You know, you're doing a study. This is a deceased donor. Why aren't we doing more of these studies? And this was actually an observation that I had made about 6 years earlier, and I published this a paper with a little bit of a rhetorical question: where is the science and what are the obstacles? At that time, there were only 6 trials in all of clinicaltrials.gov. And I think if you look up kidney transplant, you're going to find like 1,000 trials. I mean, 6 trials is just like piddly-dinks, right? There was actually almost nothing going on in this area. And so again, the question is why? Well, we've kind of, in discussing this, we kind of figured out that the primary roadblock is really we cannot map deceased donor research to existing regulations about how you review and how you conduct human subjects research. And that is because this is a real paradigm shift. This is research that doesn't fit in the box. Well, actually, some things are going into boxes for research, but what I mean is the whole package is not fitting. And that's because what's going on is you are intervening in the deceased donor. You're doing something to a deceased donor. You're exposing all of the donor's organs to whatever it is you're doing. It could be hypothermia, it could be magic molecule X. And then you're taking those organs out and you're transplanting them into a bunch of people. And before you actually even get to that step, you're offering these organs, these quote unquote tainted research organs, to a bunch of people on the wait list. And, you know, we've been talking about how our organs are, you know, they come in all kinds of shapes and flavors and types, and now we have to tell people, oh, yeah, this is a donor who has sex with men, this is a donor who does this, and by the way, you know, we've given the donor molecule X. So this really increases the complexity. There's a very compressed and pressured time frame, and there are many, many, many stakeholders, starting out with donors, donor families, donor hospitals, JCO, CMS, moving to all of the people on the wait list, moving to all the people who get the organs, the transplant physicians, the transplant centers, lots and lots of stakeholders. The second obstacle we realized was there's just confusion among professionals as to how current ethics, regulations, and legal framework applies to donor intervention research. So in order to demonstrate that, we studied this. We published a paper earlier this year where we gave 3 scenarios, and I'll just give you one scenario that's in this paper. Dr. Finnegan hypothesizes that an optimal dose of thyroid hormone will increase procurement and utilization. He's not even looking at recipients. He's just saying more organs are going to be procured and transplanted. Potential donors are authorized, have provided authorization for research. He's proposing a multi-site randomized trial at 10 donor hospitals. This is only being done in brain-dead donors, not DCD, dead, deceased donors. And the primary outcomes are just how many hearts got procured and how many hearts got transplanted. There's no interest in recipient outcomes. So we asked many people, transplant surgeons, 200 and some, OPO professionals, and IRB members, is this human subjects research? What do y'all say? Yes, human subjects research? No. Yes? Who says yes? Some people say yes, some people say no. Well, it ranged from 19% to 82%. I'll tell you it isn't human subjects research because deceased people are by definition not human subjects. But you can see that there's a tremendous confusion. Does the study require IRB review by the donor hospital? If the subject is not a human subject, it is not in the purview of an IRB, because the IRB deals with human subjects protection. So the answer is no, but there's a tremendous amount of confusion. Does the study require review by Dr. Finnegan's IRB, the investigator? And again, there's a wide-ranging variety. It almost doesn't matter whether we agree on what the answer is. Clearly, there's no agreement, so there's a lot of confusion. So you ask, well, how did Dr. Neiman do that amazing hypothermia trial? Well, he did it because the UCSF IRB said it was not human subjects research, that hypothermia of 2 to 3 degrees in the donor did not pose significant risk to organ recipients. There were no study procedures. Dr. Dieman didn't collect people's blood. He didn't collect people's urine. He didn't do anything. He didn't get anything from any transplant surgeons or physicians. And his data was obtained in a de-identified manner from the SRTR, data that was just already submitted by transplant centers as part of their obligation of being a transplant center. So that was how this was done. But you can see the limitations to doing anything that's more risky, more innovation, that involves anything that's more unknown than just lowering body temperature by 2 or 3 degrees in the deceased donor. So my last slide is really what is being done. So I'm really excited to announce that we've gone through a long 2-year process, raised $1 million, and we now have the Institute of Medicine engaged to study this question. And specifically, we're asking the Institute of Medicine to provide us with the ethical background, the ethical rationale, and the ethical framework to do research in deceased donors. We've also appealed to HRSA to deal with regulatory and oversight issues. We've gone to the Advisory Committee of Transplantation that reports to the Secretary of HHS to raise awareness and urge action by many other players in order to make all of this hopefully happen so that we can improve the quality and the quantity of deceased donor organs that we have available to transplant. So my ranting and raving earlier on about the poor organ quality is really born of my passion for trying to figure out if we can improve that by using research in the deceased donor setting. Thank you.
So hello everyone, I'm here to do the second part of the what's new and what's hot. And even though it's not as new as Dr. Feng's articles, I think the good thing about this presentation is that it has some new answers to some really old questions that we all have. So I thought we would do it as a case because, it would help to tie some of these things together. So we see a 55-year-old woman with lupus and CPRA of 25% who's been on dialysis for 5 years and comes for a reevaluation. And when you see her, everything else looks pretty much the same as it was 5 years ago, but she gives you an update. My high blood pressure went away after I started dialysis, and now I'm on a new medication called midodrine, which I take 5 milligrams 3 times a day, mostly on dialysis days, but sometimes I also take it on other days if I'm feeling dizzy. So what are the data on midodrine use in kidney transplant recipients, those who are using it prior to their transplant, and is it something that we should be looking at more carefully when we evaluate our recipients and consider what kind of transplants we are doing for them? So symptomatic hypotension, as you all know, is very common in dialysis patients, and actually 1 in 4 dialysis treatments is complicated by the occurrence of hypotension. And it can compromise the dialysis quality that you give them. It can compromise fluid removal, can compromise dialytic clearance because these treatments are often cut short. And so it's a real problem that is faced by all of the nephrologists in the community. And what are the options when you get these kind of patients? So there are different options that are used in practice. Increasing the dialysate calcium has been shown in some studies to improve intradialytic hypotension. Sodium modeling is another option that has been used. There are also other potential ways of either cutting short the dialysis treatments but making them more frequent, or doing longer duration dialysis, which may be able to achieve dialytic clearance and fluid removal without causing hypotension. But when these approaches fail, then what is the next step? And the next step is often the use of midodrine. Midodrine is an alpha-1 adrenergic receptor agonist that induces both arterial and venous vasoconstriction, leads to an increase in the peripheral vascular resistance and decrease in venous pooling, and it is FDA approved for the treatment of orthostatic hypotension, not specifically in dialysis patients, but it is often used in dialysis patients. So the research questions that this group of investigators, Dr. Al-Hamad and his colleagues had was, what are the correlates of midodrine use? Who are these folks who are on midodrine prior to the transplant? And does the pre-transplant use of midodrine predict post-transplant cardiovascular complications, graft dysfunction, and patient mortality? For this analysis, they used a very interesting sort of database. What they did is use data from 3 sources. They used data from OPTN, which keeps records on all donor characteristics, the waitlisted patients, as well as the transplant characteristics. They used data from a pharmaceutical claims clearinghouse, which had data on 60% of pharmacy prescriptions filled in the United States, including both public as well as private payers, including all sorts of basically prescriptions that were filled for these patients, and Medicare claims data, which were related to billing for diagnosis and procedures after the transplant. So they came up with a cohort of patients, 16,308 recipients, who had been transplanted between 2006 and 2008, on whom they had data from OPTN, from the pharmaceutical clearinghouse, as well as from the Medicare database. So these, as you can see here, they found that 1.7% of patients, so 308 patients out of the total 16,308 patients, were on midodrine. That is, that they had filled a prescription for midodrine within the year prior to their transplantation. 16,000 patients were not on midodrine. And this table shows the clinical traits of transplant recipients in the study according to the use of pre-transplant midodrine. So as you can see, these patients tended to be older. They tended to be women more commonly than men, tended to be white, tended to be obese, tended to be on public insurance. And these patients were more often, patients who were on pre-transplant midodrine tended to be diabetic, tended to have kidney failure, which was from diabetes, tended to have peripheral vascular disease. They were also more likely to be the ones with a previous transplant, more likely to be highly sensitized, and more likely to have prolonged dialysis duration. Living donor transplants were less common in the group that was on midodrine compared to those who were not on midodrine. And then when these patients got deceased donor transplants, they tended to get ECD, pumped ECD kidneys more commonly as compared to those who were not taking midodrine. So these factors were all significantly different between the group who was on midodrine versus the group who was not on midodrine. And this table here shows the incidence of clinical complications that was reviewed in these patients at 3 months and 12 months. So if you look at this graph on the x-axis, we have the time post-transplant and the different bars showing the rate of complications. And on the left side, on the y-axis, you see the incidence of each complication. So pre-transplant midodrine exposure before transplant was found to be an independent predictor of the risk of delayed graft function, which is not on this chart, but hypotension, acute MI, ventricular arrhythmia, cardiac arrest, graft failure, and death at 3 months as well as 12 months. So you can see that being on midodrine pre-transplant is bad news. So, and this, even after multivariate adjustments for all other factors, including the presence of diabetes, the presence of peripheral vascular disease, whether or not they got a living donor or a deceased donor, whether they got an ECD kidney or not, they found that these associations still persisted and that the risk of delayed graft function was twice as likely, the risk of graft loss was twice as likely, and the risk of death was about 2 to 3 times more likely in patients who were on midodrine compared to those who were not. Then they try to look at donor factors. They try to figure out, are there any factors about the donor that can either mitigate or exacerbate this risk of pre-transplant midodrine use in these kidney transplant recipients? And they found that the use of midodrine pre-transplant impacts graft survival regardless of donor type, but the type of donor can modulate the risk to a large extent. And in this graph, you can see the different types of donors on the y-axis. So living donor, standard criteria deceased donor, the DCD kidney, donation after cardiac death, and what was called ECD in the time period that this study was performed, which was 2006 to 2008. So extended criteria donor kidneys. And you can see that within each group, the blue bars show the people who are not on midodrine, and the red bars show the folks on midodrine. And you can find that 1-year graft survival in each group is lower for the patients on midodrine compared to the patients who are not on midodrine. But the impact is augmented in recipients of non-standard organs, and the decrement in graft survival between those who were on midodrine versus those who were not increased in a graded manner as the quality of the kidney decreased. So you can see that the difference between the midodrine and the no midodrine group in terms of graft survival goes up as you move from a living donor kidney to a standard criteria donor, as you move from a standard criteria donor to a DCD kidney, and as you move from a DCD kidney to an ECD kidney. So, and the decrements in 1-year allograft survival were larger with the use of low quality organs. And when they redid this analysis using the KDPI, which you've heard a lot about, they found that there was a 7% difference with KDPIs greater than 85% versus 2% difference if you used a KDPI less than 20%. So what is the importance of this study? The study tells us that in patients with pre-transplant midodrine use, we can expect a higher rate of complications. It informs us about the type of donor that we should consider accepting for these patients. For instance, we should probably reconsider accepting high KDPI kidneys. We should really urge these patients to find living donors if possible. And it also informs us about the impact on program performance, because right now, when you look at program performance, there are lots of risk factors which are used in the calculation of expected outcomes, and this is not one of them. So there are still unknown factors for poor outcomes, including now midodrine use, which should be calculated in your understanding of how your program is performing.
Can I say something about this?
Yes.
I think that there's sort of a, it's a yes-no deal here. I mean, I can't imagine referring one of my patients who's midodrine dependent for transplantation in the first place.
I think it is a good point in terms of when you look at these outcomes, but on the other hand, we do transplant patients with midodrine. This is a small percentage, 2% of all their kidney transplant recipients were on midodrine, and even though the risk of complications is higher, it is by no means inevitable. I think we have to also compare the outcomes of staying on dialysis and on the wait list versus getting a kidney transplant. And remember that we have certain options within our control in terms of managing these complications. For instance, I think accepting the kind of kidney that you accept, as you can see here, I think if you accept a standard criteria donor, the 1-year graft survival is still over 90%, even in those who were on pre-transplant midodrine. So even though the survival may not be as good as somebody who is not on midodrine, but I think we still have to compare that to the survival of staying on the wait list. And I think in these patients, we definitely have to think twice before accepting a high KDPI kidney or a DCD kidney. So I think there are facts, and then midodrine use is not necessarily the cause of these complications. Right, I think it is very important, because most of these patients came off midodrine after their transplant, but it isn't just a marker for poor outcomes in this population. But I think we just have to sort of, and also the strategy of immunosuppression. One may decide to use not use CNIs, if you could, potentially, in these patients, and use belatacept or some other less nephrotoxic medication to mitigate this risk of graft loss, for instance. So, so this patient decides to get a transplant from her husband. So she has some sluggish graft function, but no delayed graft function, doesn't require dialysis. Now she's 6 months post-transplant with a serum creatinine of 0.9 milligrams per deciliter. She has some anemia, but she's stable. Hemoglobin is 9.5 grams per deciliter, and is now scheduled for her 6-month surveillance biopsy at UCSF, and says, well, I'm nervous about the risk. Do I really need this biopsy? What is the risk of complications from getting this biopsy? So at UCSF, our policy is to do surveillance biopsies at 6 months in all patients, and we do 12-month biopsies in those who have abnormalities on their 6-month biopsies. So as you can see here, this was an analysis that we did of 386-month protocol biopsies at UCSF from 2009 to 2011, and we found that about 77% of patients have no inflammation. So they may have some minor non-specific changes, such as arteriosclerosis or some amount of interstitial fibrosis, but they have absolutely no inflammation and no tubulitis. About 20% of patients have what we call borderline change. So they have inflammation and tubulitis, which is not sufficient to meet the criteria for rejection. But a surprising number of patients, 7.3% of patients in this analysis, were found to have subclinical rejection. So either type 1, most commonly, or type 2 acute rejection, despite the fact that their creatinine was perfectly stable. So this is the reason we do 6-month biopsies, because we often uncover changes of graft inflammation and graft rejection, which can have an impact on which we know have an impact on long-term outcome. And this allows us to guide the management of immunosuppression, as well as potentially enroll them in clinical trials of novel interventions to treat graft inflammation, as Dr. Vincenti previously told you. So how safe are kidney transplant biopsies? So this was a study where we looked at our own cohort of kidney transplant biopsies. It was a single-center retrospective analysis from UCSF of biopsies which were performed on kidney transplants between 2007 to 2012. So we included all adult and pediatric transplant biopsies that were performed during this period, we ended up with a little over 2,500 kidney transplant biopsies in 1,600 patients. And this figure actually shows you the way that we like to do the biopsies. So the biopsies are typically done in the ultrasound suite. There is an attending radiologist as well as an attending transplant nephrologist. There are often fellows as well who are involved in the biopsies. Prior to the biopsy, a limited pre-biopsy ultrasound is done to rule out any major, complicating factors such as hydronephrosis, and to ensure that there is an adequate and safe window for doing the biopsy. After that, we generally do the biopsy under continuous ultrasound guidance. The needle is introduced angled tangentially, as you can see in panel A of this figure, and so that we get a specimen from the peripheral renal cortex, and this way we can avoid the medulla, and we can also avoid the renal hilum, and therefore risk injuring a major vessel and causing a bleeding. So that is the pre-biopsy image of a needle which is just about to fire. In panel B, you can see the needle as it enters the renal cortex, and you can see that the entire length of the needle, including the tip of the needle, is within the peripheral area of the kidney parenchyma and is nowhere close to the hilum, and this is the way we like to do biopsies. And this here is a scan. Panel C is the scan of the patient 10 minutes after the biopsy, and this is color Doppler image, and you can see that there is no peritransplant fluid collection or any active extravasation from the transplant. So this is what we like to see, but what did we find? So when we looked at complications of biopsies, we actually, going back to the cohort, the mean age of the cohort was about 42 years. They ranged from 6 months to 85 years old. 12% of those were pediatric patients. 64% of these biopsies were cause biopsies, so about a third were protocol biopsies. And we achieved technical success in 2,508 patients, which means that a specimen was obtained that was adequate for analysis. And here in this table, you can see the risk of major complications. We only looked at major complications in this study. Major complications was defined as anything that required a hospitalization, extended hospitalization compared to what was initially planned for the biopsy, and or a surgical or interventional radiology intervention and or a blood transfusion. So you can see that the total number of complications was 47 out of 2,514 biopsies. So our complication rate was 1.9%. Out of these complications, you can see that 44 out of the 47 complications happened in cause biopsies. So that was a rate of about 2.7%, and only 3 of these complications happened in protocol biopsies. That is a typographical error. It was 0.3%, not 0.03%, but 0.3%, which is still a very, very low rate of complications. Hospitalizations occurred in about 1% of patients, 27 cases. 3 patients out of these 47 required an interventional radiology procedure to control a complication of the biopsy. 15 patients required surgical exploration. Transplant loss and death was not seen in this cohort of kidney transplant biopsies. The diagnosis of a complication was made by the 4-hour post-biopsy hematocrit in about half of the cases, 49%, and imaging in about 38% of cases. And here you can see that when you look at all the complications and the time at which these complications were identified, this is a figure, and on the right, this figure in the bottom panel, you can see that on the x-axis is the time from the biopsy in days, and on the y-axis is the number of complications. About 33 of these complications actually occurred within the first 24 hours. So 25 of them occurred on the same day, and another 8 of them occurred by the next morning. And then you had a few more complications occurring serially, and no complication was seen after day 14. When we looked at risk factors, in a univariate analysis, age greater than 50 years, BUN greater than 40, lower platelet count, deceased donor transplant type, history of previous transplant, and the use of heparin, clopidogrel, or warfarin were associated with an increased risk of complications in these patients. But in a multivariate analysis, we found that the overall model was significant, but that none of these factors remained statistically significant. So your patient gets a biopsy, and unfortunately, she's in the 0.3%. So a 4-hour post-biopsy hemoglobin is 8.3 grams. The ultrasound shows moderate-sized perinephric hematoma without any active extravasation and no mass effect. She's kept overnight for observation. She remains hemodynamically stable, and she gets another ultrasound in the morning, which shows the stable size of the hematoma. Her hemoglobin in the morning is 8.1 grams per deciliter. So she feels tired, by this whole experience, as well as probably by the anemia, but she feels otherwise okay. So then you order a unit of packed red blood cells for her. So is this the right thing to do? So what is the impact of blood transfusions after transplantation? So we know that for patients on the waiting list, the receipt of blood transfusions is a strong predictive factor for the development of anti-HLA antibodies, and these antibodies make them sensitized and increase their risk of developing rejection post-transplant. What about rejection post-transplant? Yes, but what about the receipt of blood transfusions post-transplant? What is the thinking about this? So there have been very limited number of studies looking at this question, and most previous studies have suggested that when these patients are on immunosuppression, the impact of blood transfusions on the development of anti-HLA antibodies is abrogated, and that we don't need to worry too much about it. So is this true? So anemia, as you know, and as we know, is very common in the first year post-transplant, and in the early period is often due to bleeding, due to the fact that the kidney is still not working properly and not making enough erythropoietin, and due to the resistance to endogenous erythropoietin, which is due to the inflammatory milieu created by all these cytokines, the surgery, and all these issues. And in the later period post-transplant is often due to impaired kidney function, as well as the use of myelotoxic agents such as the mTOR inhibitors and Cellcept. So transfusion is a pretty common occurrence after transplant. So these investigators wanted to know, do blood transfusions after transplant increase the risk of forming HLA antibody? And if they do, are these antibodies donor-specific, and do they cause rejection in these patients? So this was a single-center retrospective analysis from France, where they took 390 unsensitized cross-match negative kidney transplant recipients. So these patients had no antibodies at the time of the transplant. They had all been tested with single antigen assays and found to have no HLA antibodies at all. And then they looked at the incidence of blood transfusions within the first year, and HLA antibody testing was done at 1 year post-transplant in their cohort of patients, and at any time for graft dysfunction. And they called the assay positive if the MFI of the antibody was greater than 500. So in their retrospective cohort, 64%, so 250 patients had received a blood transfusion. When you look at the transfusion characteristics, all of these patients had received packed red blood cells. They all received leukodepleted RBCs, which means that the white blood cell count in the unit of RBCs was less than 1 million. 22 received platelets, and 11 received plasma as well. The median time to transfusion was 3 days, and in fact, 95% of those patients had received a transfusion during the first month after the transplant. The median number of transfusions was 1 per patient, and again, the majority, 94% of them had received either 1 or 2 transfusions during that first year. So this table looks at the comparisons between patients who did and did not receive blood transfusions. And as you can see, there's a transfusion group, these were 250 patients, and a non-transfusion group, which was 140 patients. And the patients who got the blood transfusion tended to be more often women. The age was not significantly different. They tended to have received a transplant from a deceased donor. They more commonly had received antibody induction, and when they had received antibody induction, it tended to be more often depleting antibody induction. They were more likely to be on cyclosporin, the ones who had received a blood transfusion, and less likely to be on Prograf. And they were also more likely to be on mTOR inhibitors. There was no difference in the use of Cellcept, steroids, or belatacept in this group. And they tended to have a lower hemoglobin at the time of transplant, 11.8 versus 12.6 in the non-transfusion group. So when they looked at the results of who developed antibodies and what was the clinical outcome in these patients, you can see on this table here that 8.7% of their cohort altogether had developed de novo anti-HLA antibodies. These included both donor-specific and non-donor-specific antibodies at the end of 1 year after transplant. And you can see that the incidence of antibody development was significantly different between the two groups. And 12.8% in the transfused group had developed antibodies compared to only 1.4% in the non-transfused group. When you looked at whether or not these antibodies were donor-specific, you found that 4.9% overall had developed de novo DSA, out of which, again, this was more common in the transfused group, 7% versus less than 1% in the non-transfused group. So antibodies tended to be both class 1 and class 2 antibodies. The MFI of the immunodominant DSA was not very different. And antibody rejection was more common, again, in the transfused group, 6% versus 1.4% in the non-transfused group. Cellular rejection was also tended towards being significantly different, but was not statistically different. Graft loss and death, happened about one case or so, but there were not enough numbers to make a comparison between the groups. So when you look at the patients who developed de novo DSA, they were more likely to have received IL-2 receptor antibody induction versus polyclonal antibody induction. They were less likely to be on tacrolimus and more likely to be on cyclosporin. So again, in this table, they looked at predictive factors for donor-specific antibody formation at 1 year post-transplant in a multivariate analysis. And they found that the number of HLA mismatches, the number of blood transfusions, the history of cellular rejection, and the use of tacrolimus were all significantly different among these two groups. And the strongest predictive factor for the development of donor-specific antibody was blood transfusions. And those who had gotten blood transfusion had an 8.9 times higher risk of developing de novo DSA compared to those who had not. So when they looked at factors for AMR, they found that the only predictive factor which remained after a multivariate analysis was the presence of DSA versus the absence of DSA. They did not find that blood transfusion independent of DSA formation predicted AMR. So I think at this point we should really think twice when we are planning to give blood post-transplant in these patients and think about whether we really need to give that unit of blood, because the risk of sensitization exists post-transplant even when blood is given early post-transplant, and that it is significantly associated with the receipt of blood transfusions. So, and this is just a single slide to show you why we care about de novo DSA. This was a cohort of 508 consecutive kidney transplant recipients, also published this year, with a median follow-up of 75 months. And the panel on the left side, it shows you the rate of development of DSA in these patients who are followed for many years. You know, the x-axis shows the number of years post-transplant, and you can see that a significant proportion of patients will develop DSA, and many studies have now identified that the primary cause of late graft loss is chronic humoral rejection. So this is certainly something that we have to keep in mind. And going back to Flavio's point about adherence and non-adherence, actually I didn't have that figure in here, but when you look at patients who are non-adherent, the risk of having a DSA at 12 years was 72% versus 19% in those who were adherent. So certainly something to consider. And on the panel on the right side, you can see that it's a Kaplan-Meier plot of death sensor graft survival by the clinical phenotype. And the green line shows those who had no de novo DSA and no graft dysfunction. And then you have the blue line, which shows those who had DSA, but whose creatinine did not change, was within 25% of their baseline and had no significant proteinuria. And the red line shows those who had de novo DSA and also had clinical evidence of graft dysfunction. And you can see that even subclinical or subclinical de novo DSA development is associated with an accelerated decline of graft function and an increased rate of graft loss in these patients. So you're ready to discharge this patient finally, but the nurse reminds you that you forgot to select the flu vaccine options on the admission order. So she says, I can't discharge her till you reconcile the meds, and you check that box. So you go down again and check with the patient, did you get your flu shot? And the patient tells you she hasn't gotten a flu shot because she's been so busy with her transplant clinic appointments. She says, do I really need to get the flu shot? So is this a problem? Is it that important? Should we just reconcile the meds and send her home? Or should we now order a flu vaccine for her? How important is influenza in kidney transplant recipients? So influenza is a killer. And it is a worse killer in patients who have kidney transplants. So this was a brief communication from Finland, which was published this year published last year in AJT, where they presented the results of 23 patients in their kidney transplant ward. 16 of these patients were within the first month post-transplant, and other patients were admitted for treatment of complications, after the transplant, such as infections or rejection. Out of these 23 patients, there was an outbreak of influenza in the hospital, and so 7 of these patients were then diagnosed with influenza during their hospitalization, H1N1. 3 of these patients died. So you can see that the mortality is quite high in post-kidney transplant recipients who were diagnosed with influenza. So if we compare the outcome of vaccinated patients compared to those who were not vaccinated. So here in this table, you can see that 17 out of all the 23 patients on the kidney transplant unit, 17 were patients who had been vaccinated previously, and 6 were patients who had not been vaccinated. Out of the 17 patients, only 2 developed influenza infection. One of them was asymptomatic, and the other patient had very mild symptoms that resolved. When you look at the unvaccinated patients, 5 out of 6 patients developed influenza. And 3 out of these 6 patients ended up dying while they were in the hospital of respiratory failure and acute respiratory distress syndrome secondary to the influenza. So the odds ratio for influenza infection in unvaccinated patients is 37.5. So they are more than 30 times more likely to develop influenza if they have not been vaccinated compared to those who have been vaccinated. And if they develop influenza, they are 6.7 times more likely to die as a complication of this infection. So this is a very high mortality rate. So we may question whether this is indeed accurate because the previous studies of influenza in solid organ transplant recipients have reported mortality rates closer to 4 to 8%, but they suggested that in their cohort it was probably because these patients were so early post-transplant. And actually 3 of these patients who died had all received a transplant within 1 month prior to the influenza. And short time after the transplant has been identified as a risk factor for severe influenza. So one last study to answer this question, what about post-transplant? If we were not able to vaccinate the patients pre-transplant, does it help to vaccinate post-transplant? And we often say, well, you've received immunosuppression, we don't know if the flu shot is going to work, so people have mixed opinions about this. So this study, which was a multi-center prospective cohort study in Spain from 2009 to 2013, so 4-year period, 4 influenza seasons, they looked at nearly 800 solid organ transplant recipients, out of which 310 had a kidney transplant. They divided them into 2 groups. Those who were vaccinated early, this is starting 1 month post-transplant to 6 months post-transplant, and a late vaccination group. This was people who were transplanted after 6 months post-transplant, who had been vaccinated after 6 months post-transplant. So the mean age of this cohort was about 56 years, more frequently men, and 80% of these patients had comorbid conditions, including diabetes and chronic heart disease. The primary outcome was seroprotection rate, so they got baseline titers in these patients, as well as titers post-vaccination, and the success was defined as the patients with titers greater than 1:40. Secondary outcomes included the seroconversion rate, so this was the percentage of subjects with a 4-fold increase in titers from baseline, the mean antibody titer, safety, and the clinical effectiveness, because one of the questions that arises in the minds of patients as well as providers is, what about the safety of the influenza vaccine? Is it likely to provoke rejection in these patients due to a non-specific activation of the T cells? Is this something that we can reassure our patients about? So here you can see in this table the variable on the first column, and then the early group and the late group. So baseline seroprotection rate, you can see, was about 40 to 60% in these patients, and it was significantly different in the early group versus the late group. Again, suggesting that people who have been vaccinated, remember the early group is those who are within the first 6 months post-transplant. So people who have been vaccinated when they're immunocompetent, or at least relatively immunocompetent, prior to the transplant, do tend to develop seroprotection as compared to those in the late group. These are people who are more than 6 months post-transplant and do not have residual titers from last year's influenza vaccine. When you look at the post-vaccine seroprotection rate, you find that the rates are not significantly different. The influenza vaccine was successful in achieving seroprotection in about 70 to 80% of patients for influenza A, H1N1, H3N2, as well as influenza B. And these differences were not significant between the early group and the late group. So I think it's really important for us to remind patients that they need the flu vaccine, whether it's pre-transplant while they're on dialysis or whether it's post-transplant. And even if it is early post-transplant, we should make an effort to vaccinate our patients for the current influenza season. So what about was it safe and did it work clinically? So out of these 800 patients, only 9 patients developed influenza, so 1.1%. The 8 out of 9 patients were in the late vaccination group. Only 1 of the patients was in the early vaccination group. All of these patients had mild symptoms. None had graft rejection, died, or required ICU compared to the cohort of patients that we just saw previously. What about vaccination safety? Were there any episodes of rejection in these patients? So 1 patient was diagnosed with chronic graft rejection. This was 83 days after he received the vaccine. This was a patient who had been transplanted a while ago, almost 10 years ago. And when you look back at his chart, they found that the decrease in GFR had preceded the administration of the vaccine, so they did not feel that it was necessarily linked to this vaccination. So to summarize, I think all the studies that I talked about, pre-transplant use of midodrine is a strong risk factor for delayed graft function, graft loss, and death, and we should consider avoiding high KDPI kidneys in these patients. Ultrasound-guided kidney transplant biopsies have a low risk of major complications, and particularly low in patients who are getting surveillance or protocol kidney biopsies. And protocol kidney biopsies can identify early subclinical rejection, and therefore we should continue to do them. Receipt of a blood transfusion after transplant is strongly associated with the development of de novo DSA, which are known to predict graft loss. And influenza kills. The flu vaccine is safe, effective, and strongly recommended for all our kidney transplant patients. Thank you.